Hello everyone, and good morning, good afternoon or good evening, wherever you are in the world. Welcome to this Global Antimicrobial Resistance webinar, which is the first in a 6-part series. My name's Professor Angharad Davis. I'm a consultant medical microbiologist by background and clinical director for publishing and engagement for the Royal College of Pathologists. Until recently, I was one of the college's vice presidents with oversight of the college's international work when we started planning this series. And so I have the great privilege of chairing and moderating the sessions. Now, many people aren't aware that almost a quarter of RCPAS members are based outside the UK. And the purpose of this webinar series is to bring together our international members and colleagues, wherever they may be, to facilitate discussion and exchange of ideas and information between us about our different countries' situations and approaches with regards to the antimicrobial resistance crisis. We've tried to include speakers from as wide a range of countries as possible. And this also means that the Q&A session at the end is a very important feature of this series. We really hope that you will pose our speakers lots of questions and discussion points for them using the Q&A function, and we've allowed plenty of time for that. The 6-part series starts today, and we'll be delivering a webinar every week until the 12th of July. Every webinar will start with a UK speaker providing an introduction and overview of the topic and outlining the UK perspective, and then we will hear from speakers from countries across the world associated with the college. The second webinar will take place next week on the 11th of June, and that will look at antimicrobial stewardship in the community with country speakers from Nigeria and Sri Lanka. Then on the 19th of June, we will have a webinar on antimicrobial stewardship in secondary care, hearing country perspectives from Cuba, India, Nigeria, and Qatar. On the 28th of June, we'll have a webinar on engaging the public in antimicrobial stewardship, hearing from Egypt and the United Arab Emirates. On the 3rd of July, we'll be moving on to developing prescribing guidelines with speakers from Egypt and India. And our last seminar, which will be on the 12th of July, and please note the later start time for that webinar at 12 o'clock British Summer Time, we'll be looking at evaluating an antimicrobial stewardship programme. What are the measures of success? Hearing from Canada, Egypt and Hong Kong. So this slide shows you the link to the college conference webpage where these webinars are advertised. Please bear in mind that if you wish to join each webinar, which we hope that you will, you need to register individually for each webinar using the college webpage. In the red circle, you can see the logo for each webinar which shows what the tile looks like for the Global Antimicrobial Resistance webinar series. That indicates that it's part of this series. So here's our agenda for today. We will have the topic introduction and UK perspective, followed by presentations providing perspectives from Australia, Kenya and Qatar. And afterwards we'll have the Q&A session. So if you have any questions throughout the presentations, you're welcome to put them in the Q&A box below or at the top of your screen, depending where it's located on your screen, and we will aim to answer them later in the session. We're not going to take questions in between speakers. We'll take them all together at the end, but please do put them in the Q&A as we go along, and we'll deal with them all at the end so that we can have a really good discussion on the different points. So to provide our topic introduction and UK perspective, we have Kerry Phillips, who I'm very pleased to introduce. Kerry's a consultant pharmacist for antimicrobials. She leads a team of pharmacists across primary and secondary care in Aneurin Bevan University Health Board, and she chairs the multidisciplinary antimicrobial stewardship group. She's an independent prescriber, undertaking antimicrobial ward rounds and specialising in management of C. difficile infection. She's also an honorary lecturer at Cardiff University and has developed a dedicated postgraduate antimicrobial stewardship module and teaches undergraduates and postgraduates. Welcome, Kerry, and thank you very much for joining us. Over to you. I'm going to stop sharing now so that you can share your presentation.
Thank you very much. There we go. Let's just get my slides up. So welcome to the webinar, and thank you very much for the kind invitation. So I'm just going to start us off with a little brief overview of resistance, and not teaching us to suck eggs. All of us on the call know that resistance is a natural phenomenon. So the more microorganisms are exposed to antimicrobials, the more resistance is likely to occur. So even if we've got patients with a relatively straightforward infection, a urinary infection or a respiratory infection, they are more likely to be carrying resistant organisms up to 12 months down the line. And obviously, the more antimicrobials we give those patients, the longer duration, the more courses, then the higher the rates of resistance. And we know that whenever we've introduced new antimicrobials, we see resistance developing relatively quickly. So this diagram shows that on the top, we've got the first time that antibiotics were deployed in clinical practice. And then on the bottom, we've got the dates that the antibiotic resistance was observed. So in the majority of cases, you can see that resistance happens relatively quickly after clinical deployment, and probably the latest up to 3 years after deployment. But in the case of penicillins, we know that resistance had been identified before penicillin even came into clinical practice. So this is not something that we can avoid, but we do need to make sure that we use our antimicrobials prudently to try and avoid resistance developing as far as possible. And to put it on an individual patient level, I thought I'd share this, the Pseudomonas that we saw on our intensive care unit earlier this year. And you can see we have an initial isolate that is very susceptible to all of our usual agents. And you can see, unfortunately, as we started to use antimicrobials in that individual, we've got resistance developing to some of our more common antimicrobials. We then moved on, because we saw that resistance coming through, we moved on then to using one of our newer antimicrobials, ceftolozane tazobactam, and even then we saw resistance developing. So it is down to us to actually make sure that we're using antimicrobials prudently. And from a resistance point in terms of impact, we know that when we have a resistant isolate, we are having to use broader spectrum or last line agents if we have them available, or using combination treatment. We know that we have increasing lengths of stay and healthcare costs. And if we don't have those alternative agents available, then we know that patients are going to die of this. And AMR already kills more people than HIV, TB, and influenza combined. Now, longer term, if we don't have antimicrobial salvage treatment available, then high-risk surgeries and chemotherapy become too high risk to undertake. And we will see a reduction in life expectancy because people will die of infections that we find that are currently treatable. And unfortunately, this means that this will have a significant impact, not just on kind of, wider societal level, but also economic, which is a very good driver to get our governments involved in recognising the risks. So I'm sure most of you will have already seen the schematic from the 2016 O'Neill report, saying that actually if resistance levels continue to develop at the current rate, then by 2050 we will look at resistance killing more patients than cancer. So we know that we're putting a lot of money and effort into treating cancers. We need to make sure that we are putting similar resource into tackling antimicrobial resistance. And recently we've been lucky to have some publicity in the UK because we've had a new National Action Plan launched. And we have Dame Sally Davis, who's our UK AMR envoy. She's an ex-chief medical officer, and she's a very passionate advocate of around resistance. And she's warning that the rise of drug-resistant superbugs will make the COVID pandemic look minor. Now, she's always been a very good advocate, but more recently this has become personal for her because her goddaughter, who's pictured there on the right, unfortunately died because of resistance. Now, she was a cystic fibrosis patient, and she died at the age of 38 because she developed an infection that just wasn't treatable. And we know that, a lot of people are already dying of resistance. So I'm sure most of us have seen the paper in The Lancet in 2022 that was modelling the real world data from 2019. And that found that almost 5 million patients died in 2019 with causes associated with resistance, of which 1.2 million were directly attributable. Now, to put that into context, so far, the COVID pandemic has killed 7 million people globally. So resistance is already out there as a significant burden of mortality and morbidity. And unfortunately, we know that the burden of resistance is highest in some of those countries where we are least equipped to actually deal with it as well. So looking at that graph on the right, the areas in light green are all sub-Saharan Africa that have the highest burden of resistance. Now, when we look at what people are dying of, we know that they are dying of infections that we see day in, day out. So respiratory infections, bloodstream infections, intra-abdominal, UTI, etc. So these are no surprises. It's just the fact that their patients are dying because their organism is resistant. Similarly, when we look at the pathogen that is actually causing these deaths, E. coli, Staph aureus, Klebsiella pneumoniae, Strep pneumo, Acinetobacter, Pseudomonas, Mycobacterium. So again, no surprises, these are our common pathogens. So really similar to COVID, it is the fact that no one is safe until we're all safe. We know the pathogens don't respect borders, but unfortunately there is significant inequity in the ability to respond to the threat. The surveillance capacity varies significantly globally. We know that antimicrobial and lab reagent supply chains are sometimes challenges to good stewardship. And also access to newer antimicrobials, which we're fortunate to have in higher income countries, may be more limited in lower income countries, as is access to therapeutic drug monitoring, etc., and all the other things that may enable us to make better use of antimicrobials. So resistance is a global problem, and we do need to take coordinated action to make sure that we address it. So back in 2016, the World Health Organization recognized this was already a crisis. It was already a slow motion tsunami. And in 2019, it was added to the top 10 threats to global health, alongside a number of other infectious causes, as we know. In the same year, WHO published the Global Action Plan on Antimicrobial Resistance. And then a lot of us as nations have then gone on to develop our own local action plans. So within the UK, we have a 20-year vision around antimicrobial resistance, taking a One Health approach covering both human and animal health. And that's broken down into 5-year chunks. So we've just had our latest 5-year action plan published last month. Unfortunately, though, development of action plans is quite varied, and we can see across all the regions there is a range between different countries of people who have no national action plan or a plan under development, right through to those of us that have an action plan that is financially provided for and implemented in practice. So there is significant work that needs to be done around this. And similarly, as I was saying before, there is a lot of variation within surveillance capacity as well. So these look at the number of blood cultures taken, and we can see that there is significant variation and also a lot of data gaps as well. So we're not working with an equitable baseline across the globe. So what we need to make sure is that we take the usual tripartite approach to resolving these issues. So microbiology, obviously having the capacity and capability for surveillance and for diagnosis. Infection prevention and control. We know that especially in lower income countries that WASH and and sanitation is very much a driver of resistance. And if we prevent those infections, then we actually prevent the need for antimicrobials. And then obviously, if we do need to use antimicrobials, we need to make sure that we are using them judiciously at the right dose for the right patient at the right time. So I'm going to move on now to look at the UK perspective. So just to caveat this, to start off with, health is a devolved issue in the UK. So there are 4 nations within the UK. When most people think of the UK, they tend to think of England. And as you can see from the map on the right-hand side, England does have the majority of the population at 56.3 million people. The Celtic nations are much smaller in comparison, with Scotland and Wales and Northern Ireland. But because health is devolved to those governments, it means that we do have 4 separate health services. So the data that I will be giving you is from 3 of those health services, from Wales, from England, and from Scotland. So again, to put it into context, I'm talking to you from Wales, as is Angharad. So Wales is one of those relatively smaller UK nations, but definitely the one with the best flag. And I'm talking to you from Aneurin and Bevan University Health Board. So that's that blue area on that map in southeast Wales. And it's named after Aneurin Bevan. So he was a local boy who was a miner. He worked very, very hard, and he became a member of Parliament in the UK. And he went on to be the Minister of Health that founded the National Health Service in the UK. So that's who we're named after. So the data that I will be presenting generally comes from Wales. So when we look at the UK in terms of that mortality associated with resistance in 2019, we're very lucky. We're very much down the bottom end of that graph. So we have relatively low mortality associated with resistance in the UK. And when you put it into context with other diseases, we can see there the numbers attributable to AMR in 2019 were 7,580 patients. There were a lot more patients obviously associated with AMR, but we've got bacterial infections for accounting for a very significant proportion of our deaths, which doesn't really surprise, but does really mean that resistance is a significant threat if we see those resistance rates increasing. So looking at the English data, what they found is that 20% of people in 2022 had a bacteremia with a key pathogen, and the pathogens are outlined there below. They had 20% of people with a resistant isolate. So in that graph, if we look at the top block, which are in the amber, we can see that most of the antibiotic susceptible isolates were E. coli, with then a split of other gram-negatives and around about a third gram-positives. When we look at the resistant isolates, we can see that the vast majority are E. coli. So over 2/3 of resistant isolates were E. coli, with then a split between other gram-negatives and gram-positives. And if we look at Scotland in comparison, again in 2022, then the most common causes of drug-resistant bacteremias were E. coli, Klebsiella, and Enterococcus faecium. The resistance rates in Scotland very slightly lower at 16.7%. But again, you know, a significant proportion are gram-negative bacteremias. And unfortunately, when we look at the burden of AMR, it is affecting our most deprived communities. So again, these are English data. And you can see there that we've got a significantly higher burden of resistance in the most deprived communities compared to the least deprived. Now, looking more locally for myself, if we look at the All Wales bacteremia rates for E. coli, you can see some of our more recent trends and see our resistance rates. So obviously of concern is our increasing resistance to coamoxiclav, to piperacillin and tazobactam. And we've got relatively stable resistance rates to third generation cephalosporins, fluoroquinolones, and gentamicin. Cotrimoxazole is something that we have significantly increased our use of in recent years. So even though we've seen a little bit of a downward trend, we've seen an uptick within the last year's data. So hopefully that is more of an artifact and we'll continue to see it decrease. But I'm not convinced, because I think probably the resistance will follow our usage trends. One of the good news stories, though, for us is that we have very low rates of carbapenem resistance. So ertapenem, imipenem, and meropenem, we have very low resistance rates, which is obviously a positive. And to put this into context, resistance doesn't always associate with our antibiotic usage patterns. So even though we've got increasing coamoxiclav usage, that's in the context of increasing resistance. That's in the context of declining coamoxiclav usage and stable piperacillin and tazobactam use and increasing cotrimoxazole use. So you can see there that actually the usage patterns are not kind of directly comparable to our resistance trends. And when we look at some of our other isolates, so our non-E. coli kind of samples and urinary samples, you can see there, unfortunately, we don't have full data sets for every isolate. So the ones that are hatched is where we haven't actually tested every isolate. So we can't really infer specific trends from these data. But again, you see similar sort of themes in terms of increasing coamoxiclav resistance. The positive news story here, though, is that we moved away from using trimethoprim in our over 65 population a number of years ago. And because of that reduced selective pressure, we have started to see trimethoprim resistance decreasing, which is obviously a positive. When we look at the non-E. coli samples, again, we've got relatively similar trends. And then when we start to look at Klebsiella, this is where it becomes slightly more concerning, because obviously you can see from these graphs that we've got increasing resistance across a number of different antibiotics. So again, coamoxiclav and piperacillin and tazobactam resistance increasing, but similarly, we've got increases with third generation cephalosporins, fluoroquinolones, and gentamicin. And we know that this is a kind of phenomenon that has started locally within our health board. We saw some very resistant isolates coming into the area, resistant clones that were not related to our antimicrobial usage, but then because they have become endemic locally, they have then started to spread into neighbouring areas, which is obviously not good news for the rest of Wales. Again, though, positively, we have relatively low carbapenem resistance, which is obviously good news. But again, you can see there's a slight uptick there for the ertapenem within the 2023 financial year. So those are the Welsh data. When we compare it to the English data, again, we can see some similar trends. So significant coamoxiclav resistance, both within E. coli and Klebsiella. Some increasing trends, but also some positive, some decreasing trends as well. And again, relatively low carbapenem resistance, which is obviously good news. And then compared to Scotland, resistance within Scotland is remaining relatively stable from 2021 to 2022 amongst gram-negatives, and especially E. coli urinary isolates. But positively, there have been some reductions in Scotland with resistance to coamoxiclav, nitrofurantoin, and piperacillin and tazobactam. So as you can see, this is highly localised across the UK nations. So actually, where in Wales we've seen increasing resistance to coamox and piptaz, in Scotland they have seen a reduction. Looking at our Staph aureus bacteremias, you can see there are isolate numbers across Wales, across a time series, and you can see the vast majority of our isolates are susceptible, and we have relatively low rates of MRSA across Wales, which is again positive news. And then finally, in terms of our kind of specific resistance patterns, when we look at our enterococci, then we've got relatively low and relatively stable rates of vancomycin resistance. Now, I'm just going to finish off with the carbapenem-producing organisms, because obviously those are the ones that we've all seen and are all specifically afraid of, you know, when we haven't got any other options to use. So these are the Welsh data, and on the left-hand side, we've got clinical samples. On the right-hand side, we've got screening samples. And you can see there, again, we've got relatively low numbers. Now, these are all the numbers of samples that have been submitted to the National Reference Lab. And all the different colours on there are the different resistance enzymes. And you can see we don't really have one predominant resistance enzyme in play. We have a lot of OXA48s, we have VIMs, we have NDMs amongst our clinical samples, and amongst our screening samples from 2022. We've got, again, OXA48s, BIMs, KPCs, but also a reasonable number of NDMs as well. And then when we compare those to other nations, then we've got Scotland, again, similar sort of numbers. Those numbers are obviously combined in this graph. And again, a kind of mix of resistance patterns. So OX48 KPCs predominating in Scotland in 2022. And then finally comparing data to England. The English data are very slightly different because they only look at enterobacteriales, and they are split down by blood cultures and non-blood culture isolates. And you can see there again for the blood culture isolates, a mix of NDM, a mix of OX48 and some KPCs. And then on the right-hand side, we've got the non-blood culture isolates, and we have had a change of testing during that period, from which submission of confirmed CPEs from colonised patients was no longer encouraged, which obviously saw the numbers reported through to the lab decline significantly. So I appreciate that sometimes resistance and talking about resistance can be very depressing. So I just wanted to finish on a positive, that across the course of the last 5-year National Action Plan in the UK, we have seen antimicrobial exposure in humans reduce more than 9% against the 2014 baseline. And even though we'd set our targets higher, we've obviously had challenges during that period. We've had the global pandemic, but also within the UK, we had an invasive group A strep outbreak in 2022 as well, which has unfortunately set us back in terms of our progress. So it's not all bad news. You know, we can make changes to our use, we can make changes to our resistance patterns. If you want to access any of those data, then the reports are all open access online. Thank you very much.
Thank you very much, Kerry, for a really interesting presentation. Really interesting to see all those trends. Thank you to the people who've put questions in the chat. We will come on to those at the end of the presentations because there's plenty to discuss around all of that. We're going to move on now to our next speaker, who is going to give us the Australian perspective. Our speaker is Assistant Professor Caitlin Keeley, who I'd like to welcome. Caitlin is a microbiologist and infectious diseases physician from New South Wales, Australia, with interests in AMR, genomics and mycology. She's a member of the Wollongong Antimicrobial Resistance Research Alliance, which is a large-scale research initiative which analyses trends of AMR across community and inpatient settings. She's also the medical director at Southern IML Pathology and an adjunct associate professor at the University of Wollongong. So thank you very much for joining us, Caitlin. I shall put this slide down now so that you can share yours. Thanks very much.
Thank you very much. And that's right, I'm coming to you from the country of snakes, spiders, and perhaps superbugs. I'll let you decide. I am a clinical microbiologist and infectious diseases. I'll talk to you a little bit about the local context and provide some trends locally on Staph aureus, VRE, gram-negative species, and make a few comparisons. And I'll start by saying Nagambi, which is hello in Dharawal, which is the traditional owners of the land upon which I'm meeting you from, which is just in this green between Canberra and Sydney. And that's in New South Wales. So the structure in Australia is that there are 2 levels of government. There's federal and state, and the colours here divide up Australia across state and 2 territory borders, and the funding is divided along those lines. So the federal government funds basically primary care. So general practitioners are reimbursed by the Medicare Benefit Scheme, MBS, as is pathology testing and private hospitals. And then state and territory funding allocates the funding to our public hospitals and public hospital services. that impacts a little bit on how data is collected. So a lot of the data is hospital based, which I think is similar across different locations around the world. We have a thing called the Antimicrobial Use and Resistance in Australia, AURA group, which is coordinated by the Department of Health and Aged Care, established basically by the federal government, and they supervise a number of initiatives, including Australian Group on Antimicrobial Resistance, AGAR, which collects data mainly on bloodstream infections and mainly from public hospitals. There are a couple of private ones. They look at the staphylococcal surveillance, enterococcal surveillance, and gram-negative surveillance program. And then we have data that comes from the National Antimicrobial Prescribing Survey, Utilisation Surveillance Program, and then there is some passive antimicrobial surveillance that occurs. And that's all to say that, as was elsewhere, the bulk of our data does come from hospital derived data sets, which does have a higher amount of resistance partly because of the population and partly because it's concentrated with the amount of antibiotics that are used in hospitals. But really the bulk of the AMR is in the community by numbers. And I know that there was a question in the chat about factors other than antibiotic use in humans that contributes to antimicrobial resistance. Well, one of the big factors, if you look at a One Health approach to antimicrobial resistance, is the environment, is use of key cephalosporins in the food industry, and how that use then percolates through our water system, and that disproportionately affects poorer countries with fewer resources to address water supply. So Staph aureus to start with, how do we compare? We're about probably mid-range in terms of amount of MRSA, and you can see on the left the trends for MRSA over the recent almost decade. It hasn't gone up, maybe it's gone down a little bit, but what's interesting is that we are starting to see a bit more penicillin susceptible Staph aureus in our bacteremias. Now, in terms of other markers within the methicillin susceptible Staph aureus bacteremias and MRSA, there's perhaps an increase in macrolide resistance in the MSSA, but a drop in the MRSA. Cotrimoxazole or sulfur Bactrim, it's otherwise known as, has been pretty stable in MSSA, perhaps a drop in the resistance in the MRSA, and fairly stable largely for rifampicin fusidate. Now we see less MRSA in our private hospitals compared to our public hospitals. That's partly going to be demographic, also some other factors associated with the differences, and we see more MRSA in the remote areas in Australia. Moving on then to Enterococcus. So Australia is a bit of a hotspot for VRE. We don't know exactly why, and out of the causes of VRE with the VAN genes, we had an increase in VAN A, but it's flipped again, and it is predominantly VAN B that causes vancomycin resistance amongst enterococci. On to E. coli, where our group has done a bit of work. So this was a over 10-year trend looking at hospital versus community based analysis of urine samples, so not bloodstream isolates, getting a lot more of the sampling that exists. You can see that there were, for the same population approximately that is serviced, much greater number of isolates in the private laboratory data set which services community versus the public, which serviced predominantly the public hospital inpatients. And We saw similar AMR trends, though, as noted and flagged, the percentage resistance were different. So increasing across both groups. And you can see the augmentin and cathepsin resistance both increasing over time. Part of that will be potentially being driven by usage of one or the other agent, but also potentially being driven by ESBL carriage. How does that compare? Well, you can see that the hospital data was a little bit higher than the national average. The community data was a bit below. It was more concentrated with resistance in males compared with the average, and more concentrated in the nursing home cohort. In terms of seasonal trends and prescriptions, and just honing down into, what might be happening, then we did see some seasonal resistance changes in that data set. And you can see here, this is our prescription data, and it peaks with amoxicillin in particular every winter. And there are changes by season, depending on what antibiotic is being used. What is driving that, and why is it that we see the prescription data and the resistance data change seasonally? Well, we studied it, and so we've been delivering respiratory virus results by SMS to patients, and we surveyed what impact it might be having. And this is just an interim analysis, but we found that people who received these results by SMS were less likely to ask for antibiotics, go to the emergency department, and also, very nice, important, visit a nursing home. More broadly, what are trends in E. coli resistance? You can see that the ampicillin resistance has been fairly stable, but similar to the data that we saw, a slight increase in cephalosporin resistance, and an increase in MDR resistance, particularly in the hospital data sets. How are we placed compared to similar countries? Moderate for resistance, and in terms of the types of resistance we do see, it's largely the IMP resistance for CPE. So in summary, we see a moderate amount of MRSA with a recent increasing amount of penicillin susceptible Staph aureus, a high amount of VRE, which is fairly stable, more Van B than Van A, moderate amount of ESBL, and low numbers of CPE. Thank you.
Wonderful. Thank you very much. Really, really interesting to see the comparison, especially those maps, making it very easy to compare the rates that you have compared to some of the other European countries. Thank you. So thanks again to people putting questions in the chat. Please continue to do that, and we will come to them at the end of the presentations. Right, so our next speaker is Professor Guntaru Rivathi from Aga Khan University Hospital in Nairobi in Kenya. She's a visiting faculty member and examiner in a number of public universities in Kenya and India, with a professional experience in clinical diagnostics, research and teaching, having worked in New Delhi before moving to Kenya. She's also been the head of Department of Lab Medicine at Kenyatta National Hospital and a faculty member of the Department of Medical Microbiology at the College of Health Sciences at the University of Nairobi. So thank you very much. We're really looking forward to hearing your talk.
Thank you very much. I'm from Kenya. You will see the contrast after the presentation by UK and Australia, where there are formal surveillance systems for microbiology and which is able to track the AMR trends. Thank you very much again for giving me this opportunity to share a few of my reflections, my experiences, and my observations regarding AMR in a low middle income country. This is my declarations. I have no conflicts of interest relevant to this presentation. This is my hospital, Aga Khan University Hospital in Nairobi, which is a private university hospital. It's a non-profit NGO, global NGO. This is our Heart and Cancer Center. This is Medical College East Africa. And these are our accreditations. So you will see the contrast. This is a private university. quality is at the top of the agenda. So the hospital is Joint Commission International accredited. The lab is College of American Pathologists accredited. This is our ICU. This is where MDR bugs are getting cultivated all over the world. But this is a state-of-the-art ICU, one-to-one nursing. My core laboratory, chemistry, hematology. This is my microbiology section where we have bacteriology diagnostics as well as molecular biology diagnostics. Now, mind you, this is a low middle income country. And these are all the open resources for my presentation. They are all open websites. AMR is a very, very complex problem. And it is very closely related to environmental degradation, which is very, very prominent in the low middle income countries. And this is our WHO, One Globe, One Health concept. Kenya recognizes all these things. And we have even incorporated the Water Ministry, Ministry of Fisheries into the National AMR Committee to work closely with the rest of the One Health participants. And this is a philosophy from Paul Ehrlich, the father of antimicrobial therapy. Drug resistance is just following usage. The more antibiotics we use, the more resistance we will get. Antibiotics are sold in 100 kilograms. This is Alibaba.com. And this is how Kenyan farmers buy antibiotics. This is 100 kilograms for $15. And the whole box is used in the farm. And this is WHO philosophy. Addressing AMR is core to strengthening of health systems. And without this, nothing else, other bullets do not happen. So this is also recognized by our Ministry of Health. Now, I'm a member of this National Antimicrobial Interagency Committee, NASIC we call it. And these are my objectives. I have already shared with you some of my observations, and I will highlight some of the challenges, why we do not have the kind of data which has just been presented by Australia and UK. Now, this is an unusual pathogen. This is in UK, in England. This publication is from England, Shigella flexneri. But now, if we don't have a microbiology lab, how do I recognize that such a pathogen is present in my community or in my hospital? So that is the challenge we face in most of the African countries, including in Kenya. Antimicrobial resistance surveillance. This is the literature we have, a lot of literature to share with you about the low middle income country scenario where we do not have the functional microbiology lab so that we are able to make out what is the scenario, what is happening. Now, diagnostics are essential for implementation of major global health priorities: universal health coverage, antimicrobial resistance, and global health security. Without a diagnostic lab and a microbiology lab, none of these things are possible. And this is recognized. A lot of people have taken this course, online course, role of diagnostics in AMR response. And what is the availability of essential diagnostics in LMICs? This is more literature which has already been published. Lancet Commission on Diagnostics has very, very clearly stipulated that 47% of global population, mostly they are living in the low middle income countries and low income countries, have zero access to diagnostics. And this AMR mitigation, how is it possible in these countries when diagnostics are underfunded, they are not even recognized that they are very, very essential. Now, we are also advocating, WHO has advocated antimicrobial stewardship programs and an integrated model of antimicrobial stewardship, diagnostic stewardship, that is presence of laboratory standard diagnostics, and infection prevention. All these three into an integrated model is at the core of the problem. This is recognized by the Ministry of Health in Kenya. These are some of the questions. What proportion of antibiotics are prescribed and dispensed in our facility? We identified these as a top priority research questions where we need data so that actually evidence-based action can be taken. How much do our patients spend on unnecessary, avoidable antibiotics? How many avoidable complications develop because of blind antibiotic treatment? How can we increase evidence-based prescriptions and treatment of patients? Is it possible to practice good microbiology in a public facility in an LMIC? What are the barriers? What are the enablers? We have a lot of donor-funded programs which are going on all over Africa, low middle-income countries. They have a common modus operandi. They do a baseline assessment, joint action planning with the facilities, national government, and they implement tools, training materials, equipment. They provide all these things. Then they review some data and show that certain improvements have taken place. Most of the projects which are UK aid funded, US aid funded, they have similar modus operandi. And these are the training, one of the training, Fleming Fund, I was a partner, Fleming Fund country grant. I brought technicians from 78 county hospital laboratories and trained them in my laboratory. This is Aga Khan University microbiology section, where we trained these technicians for 2 weeks. But is that enough? That's a very big question. All these documents are there: national antimicrobial resistance surveillance, policy, and bench aids for microbiology lab. All these are donor funded documents are there. This is launch of all these documents by officers of Ministry of Health, and multiple SOP, standard operating procedures, documents have been developed, printed, and launched. And these are all officers and the NGO head of the country. Now, this is donor equipment donated by the NGOs, and you can see they are in the lab, but they may not have consumables because that has to be purchased by the government. Now, this is a website. An online course has been funded by one of the donors, and this is in collaboration with University of Nairobi, and this is an online course on antimicrobial resistance. And these are the recent documents: National Situation of Antimicrobial Resistance and Consumption Analysis. This is funded by Fleming Fund. The next document is funded by Find Diagnostics and GARDP. This is situation analysis of the laboratory capacity for AMR surveillance in 10 counties in Kenya. Now, the bottom line, the essence of the Fleming Fund project, which is called MAP project, is that there were 50,000 laboratories in 14 countries. Only 1.3% of them can perform bacteriology testing. That is the essence of that document. Now, the other document says that 82% of the population has access to AMR surveillance laboratories, which are 56 in number. But this picture shows that they are all concentrated in one area of the country where it is easy to travel for NGOs. The rest of the country is not actually covered. So these are all some of the challenges the partners are also facing and the national government is also facing. Now, this is from one of the documents. The green bar is Kenya. It is comparing India, Argentina, and United States. This is drug resistance index. Now, 56% is the drug resistance index in Kenya, which means 44% of the drugs will not be effective. And that is bad news. Now, this is the essence of the AMR surveillance data. For the WHO priority pathogens, green is Enterobacteriaceae, the yellow is Pseudomonas, and the blue is Staph aureus. And then these are indicator antibiotics, which are just chosen: carbapenem, third generation cephalosporin, and next is for Staph aureus. It is again for Pseudomonas, carbapenem is the indicator drug. For Staph aureus, it is methicillin. And you will see that the percentages these bars are reaching is Enterobacteriaceae, third generation is reaching 75%. And also the carbapenem resistance in Pseudomonas is reaching 50% almost. And the methicillin resistance is actually reaching 50% and above, and at least it is staying at 30%. So this rates of resistance is very, very high. But is it all over? Or is this data biased? Because it is very limited data collected from very small number of laboratories which are capable of doing this surveillance. The key problem is a lack of recognition of the role of pathologist or a scientist, microbiologist in the quality of the laboratory reports. Questionnaires do not even mention a pathologist or a scientist in these reports. And the presence of a pathologist to supervise and oversee the lab work is very, very important. That is so far not recognized. And most of the NGO activities do not involve a pathologist or a clinical pathologist or a microbiologist. Now, preliminary findings from our own data from point prevalence surveys, which are clinical points, very important. Microbiology investigations are rarely used by the clinicians. They are not used to requesting microbiology tests. Blood cultures are not done even in ICUs. AMS teams are present, but activities may not be taking place. Prescription audits are a challenge because of lack of trained personnel. Patients may be on antibiotics for 2 to 3 weeks, but there's no diagnosis. Hand washing may be challenged because of lack of running water. Reuse of disposable devices is very, very common. It's a patient safety issue. Now, this is from Aga Khan University Hospital. We generate an antibiogram every year because we have standard microbiology, which is accredited, and we generate a stratified antibiogram, but we don't circulate it. It is only for use within the hospital because it can be misleading for other clinicians. I am not presenting all the data here. We can see the disparities between Aga Khan University Hospital automated bacteriology analyzer and the public sector technologist who is sitting under the tree with a microscope trying to do that smear for malaria diagnosis or trying to help as much as possible. These are the challenges. Quickly, facility level challenges in public sector, limited funding. There is a very, very limited funding for microbiology. Maybe funding is there for chemistry and hematology, but not for microbiology. Lack of running water, patients have to pay out of pocket, faulty procurement system, and lack of budget for consumables. Equipment maintenance is a problem. Donors have given the equipment, but it cannot be maintained. Laboratories' dependence on donor-funded projects. And technical skills by healthcare workers, quality and trust by the users. The users, clinicians don't trust the lab reports. Underutilization of available capacity. Even if a test is available, the doctor is not requesting because he is not used to. And staff attrition is very high rate. Data management, because all paper-based system, there are no lab information system, which is preliminary now. It is just coming up in the past 3-4 years with the donor funding support. We have about 22 centers which are capable of doing bacteriology data. Space, congestion, sustainability of donor-funded programs is the biggest challenge. So there are a lot of lessons and conclusions we have. The most important is the ownership supported by the relevant county governments and the state responsibility, and utilization of the services by the clinicians, sensitization of the clinicians, and capacity building for AMS implementation, and quality systems for bacteriology services, and also for support some minimal fungal diagnostics and viral diagnostics. Because if we don't have viral diagnostics, those patients are not diagnosed. They are again treated by empiric antibiotics. So the absence of viral diagnostics, fungal diagnostics will also add to antimicrobial resistance. I think there is a lot of thirst for antibiotics when there is no diagnostic support by the clinicians. Thank you very much. The most important method of AMR mitigation. Thank you. Thank you so much.
Thank you very much for that really sobering presentation, and a lot for us to all to think about, and plenty for the discussion there as well. We have one more speaker before we go on to the discussion. So the final speaker today is Dr. Jamila Al-Ajmi, who I'm delighted to welcome and to introduce. Dr. Al-Ajmi is a senior consultant in adult infectious diseases at the Hamad Medical Corporation. She's assistant professor in clinical medicine at the Weill Cornell Medical College in Qatar and clinical associate professor at the Medical College of Qatar. Dr. Jamila is also the focal point at the national level for AMR for humans and for IPC with the World Health Organization. Thank you very much for joining us, and I look forward to hearing your talk.
Okay, first of all, I would like to thank the organizing team for inviting me to be speaker in this very important conference. So my talk is about, Qatar strategies to combat resistance. As you know that the WHO called countries in 2016 to develop a comprehensive national action plan to combat resistance. And one of these countries respond to this call is Qatar. So we developed our national action plan in 2018 for 4 years with a clear vision and goals. So our vision is to have a healthier Qatar free from antimicrobial resistance threat, where antimicrobials are treated as precious sources across all sectors. And also we have a goal to retain existing and develop a new national capacity for prevention and control of the MR through One Health approach. So to achieve our goal, we adapted the WHO 5 objective strategies under One Health approach, like, enhance awareness, changes behavior, to have, AMR research, to have antimicrobial stewardship program, infection control, of course, program, and to have integrated surveillance program, again, all under One Health framework. Besides that, we developed governance structures, and this is to support and to have sustainable solution to crab resistance. So as you see here in this slide, we have a national MR coordinating bureau, which is act as a core body between the board and between the national MR committees. And also we have the 5 technical group. Some of them are member in AMR committee. So now I would like to just share with you some strategies, priorities for the AMR and some of our achievement. So if we start with the awareness, education, and behavior changes, we start to celebrate the World Antimicrobial Awareness Week since 2015. And also we have included in different activities like Infection Control Week, Hand Hygiene, and also Quality and Patient Safety Week. A lot of lectures were presented to the different level of the healthcare worker and semi-governmental, public, private, and even community clinics related to the AMR prevention. Also, our focus was clinical pharmacists, so multiple sessions were conducted for the clinical pharmacists regarding antimicrobial consumption surveillance, how to use, the WHO methodology to calculate the consumption and utilization of antimicrobial drugs. Recently, there was a workshop conducted here in Qatar with the WHO UMRO. It's about, using antimicrobial consumption data to improve antimicrobial prescription. So if we go to the surveillance, we are doing good for the human sector, but we need to do more for the other sectors. For example, in human, we enrolled in the global surveillance system, GLASS for AMR modules. We started to share the data since 2019. And for antimicrobial consumption module, we started to share the data since 2022. For the plant health, actually, we have the agricultural affair, which started to conduct some surveillance on antimicrobial residue, like, fungicide, bacterial, pesticide, and agricultural groups. And animal also, they are doing some activities, like, they started to, establish their electronic system to monitor the amount of antimicrobial drugs coming or entering to our state. For the food sector, actually, they doing also some activities, like they established their surveillance for tracing some of the antimicrobial drugs residue in the food, and also tracing the antimicrobial resistance pathogen in the food product. For the infection control, actually, most of the activities, achievement done in the human sector. For example, they created their national program, and it was 5 years ago with well-established core element from WHO, and also they have active committee with clear term of reference. They develop also some policy which is published in their website to support, the community clinics and the private sectors, and still they are doing some training program related to different topic related to the infection control. And recently also they established their surveillance for the hospital-acquired infection. The next step, I think that we are going to move forward to have some activity related to the biosafety, biosecurity for the other sectors, like, animal and food safeties. The stewardship program, again, we are doing well for the human compared to the other sectors. For example, in human, Now we have antimicrobial stewardship program implemented very well in public hospital and some of the private hospital. We have a champion team to monitor, the appropriate use of antimicrobial drugs based on the culture of the clinical samples. We started also to collect some data, KPI performance indicators for the facilities, either private sectors, primary healthcare, even for the public health sectors, to assess the progress of their program. And they have antimicrobial stewardship committee in their facility to run the different activity related to the AMR prevention. In animal sectors, what they have done at the moment, they have policies to ban or restrict the critical use of some of the antimicrobial drug like colistin, fluoxetine, and they are doing annual vaccination campaign to prevent and control the endemic disease in their animal. For agriculture, actually, they have just established best practice and even a protocol to prevent LMR disease in the plant. And also they regulate the import of antimicrobial drugs in the agriculture. So research, many actually academic centers here in Qatar interested in MR in human and also in animal. We have Qatar University, they did some of the studies related to the animals, and we have a Qatar Foundation, Hamad Medical Corporation doing some research related to the antimicrobial resistance. In the last 2 years, the primary healthcare also cooperate with the Ministry of Public Health to study the behavior of the physician in primary healthcare. What is the barrier of prescribing the antimicrobial drugs among the physician, among the clinical pharmacists? And beside that, also, we did a point prevalence survey on antimicrobial use last year with the help of WHO. And just we finished maybe a few days ago data collection and point prevalence survey for the antimicrobial used at level of the GCC country, the Gulf Country Council. With the aim of this point prevalence survey is to estimate the prevalence of antimicrobial consumption in our facilities. For policy and for the publication, we have a legislation now in the place in 2002 to prohibit, dispensing of antibiotics over the counter in the community. Now we have a stewardship program. We have also a policy for the appropriate use of antimicrobial drugs, which is basically used as a reference to the guidelines that use in the facilities. We have now antimicrobial resistance report for 4 years showing the trend of antimicrobial pathogens, bacteria, bacteria gram-negative and positive, and also the fungi. Recently also we finalized our surveillance plan according to the WHO recommendation, and we have now national antibiogram. This national antibiogram will help our private sector, will help the polyclinic in the community to select the antibiotic based on the clinical diagnosis, beside the facilities antibiogram, which is already in place since many years. This is just some data about our KPI indicators. We are collecting antimicrobial consumption for the facilities based on our classification, and we're reporting our data on a quarterly basis and on monthly basis. And this is the top antimicrobial consumption consumed in one of the public hospital here in state of Qatar. And this is just graphs represent the percent of different gram-negative bacteria SPL by location, which mean from the primary healthcare, which is considered to be community, and Hamad Medical Corporation, which is the biggest public health sector here in Qatar for 2022 and 2023. And the second one is represent the percent of Pseudomonas arizona isolation from the blood, again for the primary healthcare and for the HMC for the 2 years between 22 and 23 for some of the antibiotics. And in this chart we can see for the Cefepime. This slide represents the workshop conducted last year at Ministry of Public Health. We invited the 5 technical group to work and to update the National Action Plan, the second version, and we used the SWOT analysis to identify our challenges, our opportunities to strengthen our National Action Plan. And this is another slide to present another workshop conducted by WHO here in Qatar, one under One Health umbrella, where we discuss a lot of issue related to the antimicrobial resistance. And the second one is I mentioned before that we did WHO here in Qatar workshop how to use our data consumption to improve the prescription antibiotic. We invited 11 countries from Middle East, from North Africa to discuss the challenges and opportunities to improve our antimicrobial consumption. And this is the slide to present, our finding from different workshops and the gap that we need actually to work in the next meeting, how we can close this gap to strengthen our national action plan and even to strengthen our stewardship program. So what we need to do now, I think we have a plan in our mind and it is already included in our agenda. So what we need is to have a national guidance. We need to have a surveillance for AMR in animal and agriculture, because our strategy is to work under One Health umbrella. We need also to move forward to strict antibiotic use in animal sector. We need also to have more information, more data to be collected regarding the antibiotic consumption in animal sectors, and to have their antibiogram also to help their doctor to select appropriate antibiotic based on the type of disease in their animal. We need to have more engagement from different ministries because I think to reach your target, to optimize use of antimicrobial drugs, you need to have a teamwork between all sectors, not only the human sectors. And of course, budget is one of the important, I think, challenges we're facing in some facilities to run our activities. The other thing we need to also to include the operational plan in our operational plan is the WHO recommendation to use the people-centered approach, put our people in the center of care to strengthen the antimicrobial stewardship program in our facilities, regardless community or public health or even private sectors. I think this is what I have. Thank you so much for your listening.
Thank you very much for, again, another really interesting talk, and I have really enjoyed hearing all the insights from very different parts of the world about the different challenges that are being faced. Do you think, Dr. Al-Ajmi, you could stop sharing your screen now? And then have the panel. Thank you very much. So I've seen that people have put some really excellent questions actually in the Q&A already, and we will get onto those just as soon as possible. Before we do that, I think the international team has got a very quick poll that it would like all the audience to carry out. We want to capture data on where in the world you are dialing in from. So if everyone would be willing to just quickly type in the box there which country you are attending from, that will be really helpful for us afterwards in knowing who our audience has been. Hopefully most of you have had time now to answer that poll. So we will go on to the Q&A. So I'm going to start at the top, although some of these questions are interlinked and will weave into each other really. But I'm going to start at the top with a challenging and perennial question in microbiology from Cressida Auckland. Could you point us to the evidence that longer courses create more resistance? And also, as a secondary part, is there data on rates of resistance in IV versus oral antibiotics? So Kerry Phillips, let's go to you first on that.
Okay, so I will pop in the chat the paper that that demonstrates basically the higher the exposure, the higher the rates of resistance. So that is quite an old meta-analysis now, but good evidence that is linked. I'm less clear on the IVs compared to orals. I'm not sure whether that data exists. I haven't come across it yet, but that's not to say it doesn't. But it would be interesting to see, I think. But I will pop that other paper in the chat.
Thank you. Thanks for putting the first bit of the evidence in the chat. Does anyone else have any comments on the IV versus oral? Dr. Keeley, are you aware of anything on that? There are obviously many reasons why one would want to change to oral antibiotics. Is there a difference in terms of antimicrobial resistance developing?
No, I'm not aware, but in terms of the duration, I suppose part of it is just going to be the amount of time and the opportunity to develop resistance goes up with the amount of time it's in use.
Sure, of course, and many other considerations with using intravenous antibiotics as well. Okay, so we go on to our next question. And I noticed that several of our speakers touched or not only touched on, but talked quite a bit about the use of antibiotics in animals and agriculture. So we have a question: could the high rate of glycopeptide-resistant enterococci, I think this was relating to your Australia perspective, Dr. Keeley, the high rate of GREs due to food industry practice and use of glycopeptides in livestock for growth promotion?
Possibly. I don't know the answer to that, is the short answer. Aviparsin use was a subject of campaign as a glycopeptide to reduce its use in livestock, and I don't know what occurs with importation of different foods either, different meats from different countries.
I think in Europe, it's no longer permitted to use growth promoters, antibiotics for growth promoters. Have you got any comments on that, Kerry?
I don't, but I know that there has been an awful lot of work undertaken in the veterinary sector in the UK over the last 5 years. And I think actually the veterinary sector has actually been more successful in reducing usage than the human sector, which is obviously positive.
Yes, I suppose they were coming down from a higher starting point, perhaps. Dr. Al-Ajmi, you talked a lot about, you pointed out the problems with use in agriculture. Are they used in Qatar as growth promoters?
No, actually, our regulation prohibits using the growth factors, the antibiotic as a growth factor. Then, no have regulation to avoid that yet.
Right, so you're not actually doing that, but you did mention a lot of focus on trying to cut down on the use in animals nonetheless. It's still a problem, is it?
Yeah, actually, they are doing their best to control using the antimicrobial drugs in the animals. But, at the same time, they have challenges to control the disease, the endemic disease in the animal, where they usually recommend to use the antibiotics in their animal. And we have a lot of the private farms here in Qatar, which make difficult for them, to control the use or there is overuse of the antimicrobial drug there. But I think maybe in the future, if we have clear regulation for the animal under One Health, maybe we can control that.
Yes. And how is the situation in Kenya with that, Professor Rivathi?
We have very little vancomycin resistance. Rarely we see enterococci, which is vancomycin resistance. In fact, in my lab, I think in the past several years, I have seen maybe 15, 20 isolates. And they were a few urinary isolates, 1 or 2 blood culture isolates, then they disappeared. So we kept them in frozen stock to characterize the mechanism. But we haven't done it yet because we'll have to, do some sequencing and map the resistance genes.
Yes. Does that reflect a low use of vancomycin in your facilities then?
Yeah, vancomycin we have restricted. It's a restricted antibiotic. It's not like an empiric like USA. It's a restricted antibiotic, and we don't have vancomycin resistance in Staph aureus in the country. Touch wood, thank God. We have not seen any confirmed vancomycin resistant Staph aureus so far.
No.
There are reports, but they are all, lack of internal control. The antibiotic disc not working. Suddenly a tech reports that I have a vancomycin resistant Staph aureus. Then I bring it to the lab and confirm it is actually susceptible.
Yeah.
So far we don't have
we don't see vancomycin resistant Staph aureus, but it's more the enterococci. I think that. Do you have any data on enterococci?
Our enterococci are more than 60% susceptible to penicillin, ampicillin. That is our drug of choice. And we see a lot of urinary tract infection, not so much blood culture isolates, only in hospitalized patients, ICU patients now and then with urinary complication or procedure. And we treat them with intravenous ampicillin. We don't need to go to any other drug. Mostly they are susceptible. But a small proportion which are resistant to the combination, that is high-level strepto or high-level gentamicin, we resort to the other drugs. Yes. But vancomycin is used empirically in endocarditis before we get the blood culture reports. So it is restricted, it is stopped after 24 hours. And 48 hours onwards, it is stopped.
Thank you. Kerry, the next question was specifically to you. You state that antibiotic consumption has reduced since 2014. Is that in absolute terms? Or is it in kilos, or is it relative in terms of kilos per patient?
So that is in terms of the rate. So that reduction, that 9% reduction, is defined daily doses per 1,000 inhabitants per day. So it is a rate. And there was a question that was kind of linked as well. That, apologies, I moved over into the answered pile. But asking about why the most deprived areas in the UK have a higher amount of resistance.
Yeah.
I don't think we fully understand that yet, and that is something that has been put into the research priorities for the next 5-year National Action Plan. But there has been some local investigation into primary care usage in Wales, and there was higher prescribing in areas of socioeconomic deprivation. But they found out that it wasn't explained by the differences in chronic conditions or smoking status or other factors that are usually kind of related to deprivation. So it was actually an unexplained link. And there's a lot of, I think, behavioural elements to this that need unpicking, because locally I have a number of areas of action within the health board. But we have one who are actually very low prescribers and then two that are very high prescribers. So there is even disparity between areas, I think, as well.
And Professor Taiwo is asking you specifically as well, Kerry, whether there's been a decrease in AMI in the UK with our 9% decrease in antimicrobial use in humans over 10 years.
I don't think there's a nice kind of easy, oh yes, we have. As you can see from the trends, the trends are going up and down. I mean, locally, we've seen that reduction in trimethoprim usage and the reduction in resistance that's gone with that. So that's obviously a positive. I think probably looking at a kind of like, global perspective across the UK, we've seen the resistance rates are relatively static, where we're possibly anticipating an increase. So maybe there's been that kind of like impact in that way, but I don't think we've seen we've reduced this by 9%, therefore we've seen the knock on.
It would be very nice to see that, wouldn't it? But yeah, perhaps it's not that simple. Professor Privathi, Kate Woods is asking whether you could provide the reference for your figure 12 about key indicator bacteria and resistance patterns.
Yes, it's on the website of ASLM. There is a link. I can put it in the chat box.
Oh yes, if you could put
one can download all the country data.
Put it in as a question, because the audience can't see that only the panelists are using the chat box. So if you could put it in the question box, then everyone will be able to access it.
Okay, let me do it.
Thank you very much. Fantastic. Thank you. Can you tell us again the website that you said we can find it on?
It's Africa CDC website, and the project is called Mapping Antimicrobial Resistance. If you say MAP, M-A-A-P, the documents will come up, and it has all the documents for every African country, 14 countries, which were, the data was collected by, this was Fleming Fund.
Sounds like a great resource.
Yeah, and then Kenya has a separate document, Zambia, other countries, 14 countries. And it's a very, very revealing document to
brilliant, thank you.
About the current situation.
So next we have a question for Dr. Al-Ajmi. What is the culture of prescribers, especially physicians in Qatar? Are they open to challenge, or do they regard challenge as a threat to their status and power?
Yeah, okay. Regarding the physician, we face some challenges, from some of the physician, but I can say that those who's working in public health sector is better than those who's working in the community, because maybe we have well-established research program in the public health sector, and we have a team who's doing, round on daily basis restricting antibiotic use. But still, some of the physicians reluctant to change the antibiotic, for many reasons. Sometimes the patient, let's say in ICU, very sick, and they cannot just follow the guidelines. They want to save the life of the patient, and the waiting culture result sometimes it takes time, especially for a specific type of organism. So still, we are not doing well, I can say, but we are improving compared to the years ago regarding antibiotic consumption. But this is in some facility, like, as I said, Hamad Medical Corporation, which is the public health hospital. In the community, there is a lot of issue related to the challenges of the physician. And this is why we did that study regarding, assess the behavior or barrier of the physician to follow the guideline. And one of their, barrier is because they're receiving a lot of pressure from the patient to give them the antibiotic, and they don't have the rapid diagnosis test, so they can decide to give or not. Besides, most of the time they have heavy work and they cannot just go and check the guideline. So there is many barrier. We need to solve this barrier, so to help them to change their concept and their behavior. But yes, we are like any other country. We have the challenges. I think we need that time to do that and to change the behavior of the physician.
And I think something else that you've touched on there is the importance of diagnostics, and where people have a rapid diagnosis, then they're more confident in cutting down on prescribing, isn't it?
Exactly.
And perhaps that's something that doesn't always get the attention that perhaps it should, as being a really critical part of the process. Right, let's move on because we have lots of questions left. We have a comment from Dr. Ben Ishmael that compliance and completion of treatment course will be crucial in avoiding AMI in oral regimes. I think that may be referring to the discussion about IV versus oral, and that there might be some disadvantages of oral in terms of making sure that people adhere to the correct treatment. So then we have a question, yes, and this was one that occurred to me as well in Kerry's talk. How can we explain the increase in co-amoxiclav resistance despite reduction of consumption? Have you got any hypotheses for that, Kerry?
As you say, it is the great unknown. I mean, I think your suggestion of a lag effect is probably true. We did used to use a lot of co-amoxiclav and piptaz across Wales, but we did probably change away from that around about 5 years ago now. So it depends how long we're expecting that lag to take. Certainly the changes that we've seen with trimethoprim were more kind of contemporaneous and have resulted in that kind of reduction relatively quickly. Maybe there's different issues at play with co-amoxiclav.
It was interesting that you said that Scotland hadn't noticed the same thing. Did they historically have a lower use of co-amoxiclav? Do you know?
I don't know off the top of my head, but I suspect they probably have done, because they've always been very good antimicrobial stewards in Scotland. Their programme was developed quite a way ahead of some of the other nations, so they were probably on top of it, but I don't know, but that's a guess.
Anybody else have any comments on the lag time to seeing any changes after reducing the use of antibiotics? Oh, Professor Rivathi, you have your hand up.
Yeah, regarding this co-amoxiclav resistance, I think UK described a different mechanism of resistance, trick enzymes, enzymes which are resistant to inhibitor combinations. Maybe they are spreading, even if you are not using. It's a complex chromosomal type plasmid mediated. The molecular biology I don't understand so much, but it's a trick enzyme, Temonera type, resistant to inhibitor combination. Maybe that is spreading and you are not using so much of co-amoxiclav. I don't know, just a loud thinking.
Interesting, thank you.
One thing that can influence it is if it's driven by, for example, an ESBL and a plasmid, then something that will drive the retainment of a plasmid will increase resistance to every marker that's in that plasmid. So for that reason, trimethoprim is thought of as worse than nitrofurantoin for UTIs, because trimethoprim resistance is often in that plasmid. So having that pressure will also increase the rate of carriage of ESBLs, whereas nitrofurantoin concentrates in the urine, has very limited microbiome impact and doesn't have that same pressure resulting in ESBL carriage.
So multi-drug resistant plasmids being spreading and therefore not being related to just one antibiotic. So yeah. So we actually, in terms of the time for the recording, I think that is going to end at 11:30, but we still have some good questions. So I think we'll carry on. And if the recording if people watching the recording miss the very end, then that'll be unfortunate. But I'm sure that people here would like to get to some of these questions. So we have a question. I am a clinical microbiologist working in India. I'd like to know your views on how to integrate One Health approach with our clinical microbiology. So far, mostly dealing with diagnostics. It would be great if you could provide a couple of examples of how you approached this. Has anyone got any comments? I think that's about integrating the One Health and human microbiology, I think. Yes, Professor Rivathi.
I used to think I never understood this One Health. How does it work in a hospital for a clinical microbiologist? So this is my IPC guys who told me the environment in ICU regularly monitoring, because it went out of fashion. They said environment has no role, but now ICU environment, hospital microbiome is a topic now. So there is a PhD student who wants to work on this. So environment, you can check the community surrounding of a particular patient when he goes home and within the hospital. And then zoonosis, of course, we have all these, we have a lot of brucellosis, which is coming up. We never used to see that in my hospital. We have seen 10 patients in 2 months. Something is happening. So we need to go to the farm and check what is happening and what is the connection between the city dweller and the farmer. So that is how I think One Health comes in. How is this spreading happening? But I think it's a lot more than that. Thank you.
Thank you. Anybody else want to comment on that?
Yes, please. Maybe I can say something. One Health approach is not something easy. You can do it within one day. You need to know cooperation, engagement from all sectors under One Health umbrella. So what we have done here in Qatar, we, as I presented in the slide, we have 5 technical groups. And in each of these groups, we include people from different sector, from the food safety, from animal, from environmental, and so on. So we are working together so to find some way how we can, enhance One Health approach for antimicrobial resistance, sharing the data between other and also including them in our activities in developing our national action plan. This maybe will help to initiate the One Health approach. We are thinking to have an integrated surveillance system for the antimicrobial resistance pathogen to be one system for all, for the animal at least, and the food and the human. It takes time to develop it, but we initiated this process. So if you have surveillance system to cover the whole country and to reduce LMR, which is, I think, clinical microbiology is one of the elements in this, integrated surveillance system.
Great, thank you very much. I think we really do need to wrap up now. It's half past 11 UK time, so we are running over thanks to such a great discussion that we've been having. But I am going to wrap up. So let's go to our final few slides. Yes, so all the webinars in this series are going to be recorded and stored on our website in the International Regions section under the category Virtual Resources, which you can see here in the red circle. So we aim to upload our recordings to the website about 2 weeks after each webinar once they've been properly edited. So you'll be able to see them there. We do hope that you will join us at our next webinar, which is on the 11th of June, at 10 o'clock British Summer Time, where we'll be looking at antimicrobial stewardship in the community. And there's a link there, which you can also find on the website to register for that. Just to remind you, the international team will also be delivering International Pathology Day on the 6th of November on the theme of antimicrobial resistance this year. So there's also a link on the website for you to register for that if you would be interested. We'll be sending around a brief feedback form after this webinar, and we'd really appreciate your feedback on the delivery of this session. It won't take long at all to complete, just a couple of minutes, and it's anonymous. I would now like to thank very much our excellent speakers, Kerry Phillips, Assistant Professor Caitlin Keeley, Professor Guntru Rivati and Dr. Jamila Al-Ajmi for fantastic presentations, really, really interesting insights into their parts of the world. And also a huge thank you to Giles Hanratty from the international team at the college, who has done amazing work putting this series together. And thank you to everyone who's attended in the audience. I hope you've found it interesting, and we hope to see you in the following webinars. Thank you very much. Have a good rest of your day. Goodbye.
Thank you. Thank you, everyone. Thank you.